Hey Mo,
Hey, hey, Ricky.
the doctor is in.
Yes, we are on this Wellness Wednesday. We are in, and we're in on the cusp of or just after the San Antonio Breast Cancer Symposium.
Yes,
So for people watching, San Antonio Breast Cancer Symposium is one of the world's largest meetings of the minds and sharing of information. What's new, what's hot, what's current, where are we, what is the status update, and what should we be looking forward to and looking at in breast cancer care, whether it's surgery, chemotherapy, radiation, advocacy and survivorship, all the things. And a lot of science was talked there, a
a
lot
lot
of
of fun.
science, a lot of posters, right? And this is a good chance for us to talk about something that we're starting to hear more and more of, which is circulating tumor DNA. How do we know cancer is gone? How can we detect it in a bloodstream or in some sort of a liquid biopsy form? And we're getting some answers here. So this is a great topic today.
It's a great topic, and I met these lovely ladies a few months ago, and they have just given us such a wealth of information. And I really kind of met them through Latoya, right? So our baby breastie, and I think that we have Latoya and Nikki here to kind of illustrate the impact of these tests as breasties. So I think we should let Caitlin and Jamie, you guys introduce yourselves, and then we'll let our breasties introduce, and then let's talk about explain what this science is all about. This is like amazing science that we all need to know about, and I think we're going to be really well informed. So, Caitlin, who are
Yes.
you?
Yeah. Hi, guys. So my name is Caitlin, and I am a nurse practitioner, and I practiced in the clinic in oncology for about 7 years before I joined Natera. And now I work for Natera as a medical science liaison within the medical affairs. And my job has been to focus on Signatera in the breast setting. But before I start diving into the science of it, I'll let Jamie introduce herself, and then we can start talking about the science behind ctDNA.
Great, Jamie. Great to
Hi,
have you.
everybody. I'm Jamie Schwartzbach. I work for Natera. I'm on the marketing side of things. So I help build a lot of our patient materials. So anything you've seen regarding Signatera, I probably helped work on it. And one of the things I do is actually work in patient engagement. So I work with a lot of advocacy organizations, make sure that everybody knows that Signatera is available, and answer any questions. So thanks for having us.
Awesome. So thanks for being here. So let's, break this down to me like I'm a 5-year-old. Like break it down.
Right.
What are we talking about here? What is this amazing science?
Definitely. So I think the first thing that's really important to keep in mind is, what are the 3 questions you always have as a patient? One of them is, how do I know all my disease is gone after surgery? So you went through the lumpectomy or you went through the mastectomy. How do I know all the disease is actually gone? That's question number 1. Question number 2 is, maybe you are on therapy in many different types of settings, but you want to know if you're responding to the therapy that you're on. And then number 3, you want to know when your diseases come back, right? So those are the 3 most common questions most patients who have experienced breast cancer in many different forms and histologies typically ask. So Signatera is a great tool to help answer those 3 questions. But very first, what's pivotal to understand Signatera is to also understand what minimal residual disease is, or molecular residual disease. It's the same thing. For short, you'll hear people say MRD. And MRD is basically a fancy way of being able to identify cancer in very small amounts in the blood. And when we talk about Signatera, we're just talking about finding circulating tumor DNA in your blood. So typically, how cancer has been identified for recurrence or being present in the body is by imaging. So, you can get CT scans, you can get mammograms, MRIs, and those show masses if you do have cancer on imaging. For cancer to be present in a tumor, it's about 1 billion cancer cells. So you have to have around 1 billion cancer cells to really even show a tumor on imaging. So right away, you can kind of see, you can have a lot of cancer cells before even present on the current standard of care, right? So I think that's the very important thing to understand. So to bring it back to Signatera, what we're doing is we're basically looking at tumor-informed residual disease. So what we do here at
Hey,
Natera.
say that again. Say that again. Tumor informed residual disease. What does that mean?
Yes, so
Break it-
very unique, because this is not a panel test. In other words, we're not just testing for mutations on a panel that are most commonly associated with certain types of cancers. Instead, what we're doing is taking the tissue from your tumor and doing testing on it to identify mutations in your disease. So a really easy way to remember that is Signatera, the first three letters, SIG. I remember it's signature. It's a signature of your tumor. It's like a fingerprint of your actual disease. So in other words, let's say you have three friends and you guys all have breast cancer and it's all triple negative. They still can behave very differently, right? And that's really what Signatera focuses on. We're making your disease very unique because we know it's unique to you and your experience. So when we take the tissue, we do something fancy called whole exome sequencing. And what that does is that we're just looking at all the mutations in the tumor. Some tumors have more mutations, some have less. But what we do is we identify the mutations that are present in almost all of the cancer cells. And when we do that, we identify them. We then make a test where we look for those mutations in your blood. So we're looking for the presence of it in your blood, which would represent a circulating tumor DNA, which
Go back for 1 second. What's a mutation?
so a mutation is something that is in your tumor that is going to continue to change and morph, and there can be very unique mutations that aren't in all of the cancer cells. And then there's other mutations that have been present at the very first cancer cell. So when we select the mutations, we make sure we select the ones that all look very similar. So in science words, that would be saying clonal. So we're selecting the ones that are present at the very beginning of your tumor being developed. So by doing that, we are identifying the mutations that are present in the most cancer cells. So when we select them, we're making sure we're selecting those specific cells so that are mutations so that they're going to be present, and we're going to be able to identify the disease at a much lower level than traditionally.
So it's what your cancer looks like. Nobody else looks like this.
Correct. So the mutation selected for you could be totally different from the patient sitting right next to you with the same disease, same stage, and same pathology.
Pretty cool. Pretty cool.
Yeah,
So
so
you're fingerprinting us, sort of.
Yes. Yeah, it's
Fingerprint
the
our
fingerprint
cancer.
and the signature of your tumor.
Okay.
So when we do that, we're able to identify after surgery. So that's what we call a true MRD time point, minimal residual disease. We want to see if all the disease was removed in surgery. And we can tell that by using Signatera. We also can use it to see if you're responding to therapy. So is the result, if it's still positive, is it trending downward or is it going up? So for example, if you're on chemotherapy and you have a positive Signatera, we also give an MTM per ml. That's like a number associated with the positive test. And that being said, let's say it's 15 and then you start chemotherapy. That 15, if the next time it drops to, let's say 8, it's still positive, but it's a lot less. You
Or
see, so
something's
that's really
working, yeah.
reinforcing you're responding to the therapy. Does that make sense?
Great. So you can take this test while you're on chemo or in therapy to know whether it's working or not. Hello, how cool is that, right? Because
Yeah.
so many times you don't get a scan for 3 months.
Yeah. And think of
How
all the
does your
times.
readout? Does it
Yeah.
tell you that it's low? Is your number low and it's like, okay, minimally detected, or is it your score like 0? And what happens? I guess the next question is, how accurate is it? Because I kind of know some of these answers, but I want people who are watching to get their questions answered as well.
Yeah. So for the report, you get something called an MTM per ml, which that's giving you a number. So you're able to see if it's 0, that would be a negative result, or you could see it being much higher than 0, which would be a positive result. So the benefit of having that is that you're able to trend those MTM per mls. So a positive is not just a positive now, right? Like you can trend the positives and see if it's going in the right direction or not. So like, let's play devil's advocate against the last story I told. Let's say you're on chemotherapy, you have a positive test before you start and it's 15. I'm just going to stay with 15 just for sake of the conversation. And then you start chemotherapy, you repeat it again, it's positive again, but instead of being lower than 15, let's say it's 55. That's actually showing, it's still positive, but much more positive. And this might be indicating that I'm not responding to the therapy.
And how cool would that be able to know, you know, because we don't know you're in this, you're plugged into the port thing and they're giving you drugs and
Right.
that it's working, but we don't know. So to be able to have an indication.
Yeah.
and
How
I-
often should one test? Because I know my colleagues are afraid. I've got a really good friend, Christy Funk, of course, who's a big fan. She's with Pink Lotus.
Yep.
And she's a surgeon who's using this test. But the surgeons are like, well, what do we do? What if your number was 5 and now it's 8?
Mhm.
Our patient's going
Yeah.
to be worried about that. What if your number was 10 and then it's now 12? Like, how do you, how do doctors, how are they using this information, I guess, when you're in remission, so to
Mhm.
speak?
Yeah. So we have a lot of doctors who I work with, and what they're doing is what we call cadence, which would be the frequency interval. So we have a lot of people who do it every 3 months. And if it tests positive, then they'll go to a quicker interval. So like, let's say you do it every 3 months, negative, 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 then it tests positive. Instead of waiting a whole other 3 months, they have changed that cadence to like 12 weeks, or sorry, excuse me, 6 weeks. So trying to assess to see if that positive is growing rapidly or not, because you could test positive and let's say like, again, 15. And let's say you test again in 6 weeks instead of 12, right? Because we're going to do a quicker interval because it's positive. But let's say it's 17 the next time. It's more concerning when it's reflective of a very aggressive disease, when you see that number rapidly going up. So in oncology land, we talk about doubling or tripling of numbers. So like if the 15 went to a 30 and then the 30 went to a 60, that would be a signs of something definitely occurring and brewing quickly. Where if you see like 15 and then 17, you might repeat it again, and it very well could be 15 again,
Mhm.
right? So
Let's
there's
pull in
different
For
situations.
signs, right?
Let's pull in some patients. And my question for our advocates on the panel is this information helpful, or is this a number you're going to perseverate on and focus on and be wanting to trend and track and use that number to tell you if your cancer's back? How do you feel like this information helps you?
So I would say that I received I'm 36 years old, triple negative breast cancer, stage 3C, July last year. And so I went through all the standard chemo and radiation and then surgery. And when I found out about the trial using ctDNA post mastectomy and post radiation, and I was able to qualify to get the DNA testing done, it was more so like of a reassurance level that all of the cancer is gone, down to a microscopic level to check in my blood cells. So I was very excited to learn about that. I actually cried when I got the news that, okay, that all of the disease is gone, because we know that that may not be the case in every situation. And so I was very excited to hear that my results was negative at baseline, and that in the study, I'll have intervals where it's checked to see if there's any changes in that, because the ctDNA is working in a collaborative approach with the trial, because they're using investigational drugs to help people with triple negative breast cancer, to say, okay, after we went through the standard of care treatment regimen, we got the tumor out, she went through radiation and cancer. Now we're trying to develop another drug that can combat triple negative. As we know, triple negative is the most aggressive because we lack those receptors where we don't have the targeted therapy like other types of cancer. So I think this is very groundbreaking for us to receive this test. And I think that every single cancer patient should receive the test if available.
Yeah, and Mo, being a TNBC survivor, and so is Nikki too, is that we're the only breast cancer subtype that doesn't have a drug to prevent recurrence. So everybody else can like take something for 5 years, and they all complain about tamoxifen. I wish we could complain, we can't. So this is just a great thing to have, because we don't have a lot of confidence that it's not going to come back.
Yeah.
So Nikki, I'm sorry, babe.
Yeah,
Yeah, I
Nikki,
was
you
gonna
sent
say-
us the recording. We were like celebrating with you.
Yeah.
Yes. So my story is a little different than Toya's. I didn't do the clinical trial. And at first, once I heard about the ctDNA through Toya, actually, or it might have been through you or Ricky. I'm not exactly sure, but I know Toya was really pressing me to get it. And so this was after I had done the double mastectomy. I'm sorry, I was diagnosed stage 1B, it progressed to stage 2 in a matter of a few weeks. And I started chemo in October 2021. And I just finished in October 2022 with a double mastectomy, reconstruction immediate. And at first, when I talked to my doctor about it, once Toya told me about it, the nurse practitioner and my doctor was like, no, Nikki, we're not going to do it because we don't know what to do with these numbers. They didn't know, once they test and the results come back or numbers come back, what did they do with that? Because there wasn't any further study, I guess. Mm-hmm. And so I was like, okay, fine. So then a few months later, Toya was like, go back and ask him again. And I went back and I asked, and my insurance covered it. He fought my oncologist, Dr. Chang, for UCBC in Athens, Georgia. He fought for my insurance to cover it, or maybe the center covered it, but I didn't have to pay anything. Good. And the voice, I'm gonna see if it's like less than 30 seconds long. Can I play it?
Yeah.
Play it, yeah, because it was a hurrah moment, right?
Yes. Okay. Okay, here we go. Oh gosh, I hope this works. Here we go.
Dr. Chang's office.
Can you hear it?
Just wanted to give you a call and let you know that your Signatera testing came back, and it was negative. That means that nothing was detected, which means that either there truly is no cancer to be detected, or the level is just so low, it's below the threshold of what they can detect. So either way, very good news. Just wanted to let you know. And if you have any questions at all, please just let our office know. All right. Thanks. Have a great Christmas.
And so hearing that message because after I had gotten the double mastectomy back in April, he was like, Nikki, there's a little bit of cancer left. So we're going to put you on, Cape Satie, Xeloda, and Xeloda, and continue me with Keytruda. Mm-hmm. So now I was like, do the CT. That was in April, May. And he was like, no. So then hearing this news now, and then not having to pay for it because I'm not working. Mm-hmm. It's just, and I'm listening to you, break it down, because I'm just listening to Toya. She's like Advocate 101 class, she's a professor of the class. And so I didn't know all of this to know, okay, so where do I stand? So I'm gonna call him tomorrow and be like, what's my number? So then when I go back in like 3 months, 2 months, 3 months, or how often he wants me to test, and make sure that that number stays progressively, is trending low,
Yeah, and
but
if you are negative, the MTM per ml is 0.
0.
Okay, well then there's that.
So that's what you're paying attention to. And like, just to clarify, when you have a negative, it means that they're not finding those clonal mutations in your blood, like the circulating tumor DNA from those clonal mutations. So just to like kind of dive a little bit deeper, like when you have the cancer cell, so you have one cancer cell, can't see it on imaging, but when it sheds or replicates or makes a new cancer cell, it releases that circulating tumor DNA into the peripheral blood. So that's what we're identifying with that blood draw. So if we're not finding ctDNA at a very low level, there's not cancer cells making that ctDNA. So if you're negative, we're not finding any of it in your peripheral blood at a very, very, very low level.
Wow.
Which
That's
is far
news.
before imaging. Yeah. So
when should she do it again? When
Can I
should she do it again? When should she do it again?
So if what I have seen a lot of physicians do in the surveillance setting with breast after you've gone through all the treatment is they would repeat it in 3 months. And then if it's negative again at 3 months, you continue doing it every 3 months. For the first, what we have seen physicians do, because again, your physician is picking this. They do that for the first few years, and then they can go a little bit longer. But that's a conversation between you and your physician to come up with something you're both comfortable with. Because if it's not a financial burden and it sounds like you don't have to pay anything, and you want to get it in 3 months, then that's
Why
very
not?
appropriate.
So every 3, or does it then track out to 6, then a year, 6 months, then a year?
So currently, right now, most physicians are continuing every 3 months in that surveillance setting. But again, as you move on through the journey, they might want to do it less often. But that I would have that conversation with your physician. You guys can come up with something you guys are both comfortable with. And if they're having a hard time coming up with something they're comfortable with, they can always reach out to Natera, to our clinical oncology specialist in that territory, or medical affairs, and we can help guide that conversation too.
Thank you. It's good to know.
Wow.
But
Wow.
I'm so happy it was negative. That's awesome. It probably makes you feel really good. And I'm really happy to hear that, because we always hear a lot about, the anxiety of the test, but a lot of people don't focus on the negatives and how the negatives really remove that anxiety. So that's awesome. And I'm really happy for you.
I think it's more of a mental thing. I mean, granted, yes, it didn't show up in the blood, but now it's a mind shift of now I feel like I can live freely as opposed
Control
to
your
being
life a
bound by,
little bit.
right,
Yeah.
right.
That's awesome.
Great.
Kind
Toya,
of like insurance.
yeah, what was your
Yeah.
experience, Toya? What was your experience?
I mean, like Nikki, I see Nikki is emotional about it. And I'm glad that I kept bugging her about it to get the test, because I wasn't taking no for an answer. I'm pretty stubborn. So
We know.
yeah,
No, not you, Toya. Oh,
I love that. I love that about her.
So yeah, I mean, it was just kind of like, it was just more so like it was a victory. For me, I felt like it was a victory when I got that result, because it's like it was kind of like insurance, that it was some form of reassurance, like this is a liquid metastasis test that's stating that, hey, you don't have traces of cancer that can be detected in your blood right now.
Right.
And so what I think that, and I know that there are physicians that push back against it, because my primary oncologist refused to order it
Mhm.
because her, and like Dr. Mo was saying, she has colleagues who are saying, okay, well, what do I do with the test? And so that, I know that has been an area of dialogue that Natera has been, advocating for patients too, is because physicians are pushing back on the test, some, because they're like, okay, well, what do I do with this result?
Mhm.
And I would say to them is that there is published data about it. From even I read one earlier today from Dr. Weinberg, who is a GI oncologist. And he in a particular case scenario, he published this case scenario with his patient because he was drawing CEA levels from a patient who had colon cancer, and the CEA levels they're not as specific for as a ctDNA test. And so the patient had went through receiving a colon resection, having the tumors removed from his colon. And then he actually went ahead, he was hesitant about it at first. CA levels were still negative, and then he ordered the ctDNA test. And then he repeated it twice because the numbers kept trending upward, even though this patient was post-op. And so once they did another PET CT scan of this patient post-operatively, they found a 3 centimeter tumor in his liver, because the ctDNA levels were trending upward, whereas the CEA levels were negative and they're not as specific.
Mhm.
And I think that, it's great that the ctDNA test is more like a quantitative, test versus, like a qualitative test. And so
Now, that's
I
really
think
useful.
Ex-
That's
explain the-
interesting.
Yeah, explain the CEA test, because that's the one I've been taking for years, right? Just to understand whether my cancer came back, which tells you nothing. Also, I want to go back to 1 second. When we say liquid biopsy or liquid whatever, it means a blood test, everybody, just a blood test. They're drawing your blood. That's all.
right.
That's what
That's it.
it's a blood test. But go ahead, explain the CEA.
Right. So like the CEAs are carcinogenic embryonic tests. And so like when we're babies, that we have this protein when we're in fetal development, and this this protein is found in certain organs such as the colon and the prostate, the ovaries. And so that test, sometimes oncologists will use that test, through blood draws to see if a patient may be having this test detected in their bloodstream, but it's not 100% specific. And I'm sure Dr. Mold, Caitlin can comment more on it in the oncology space. So, but that's kind
The
of
reality is there's no really great tumor markers in the blood for breast cancer, right? It's not
Right.
like even the CA-125, I got a family history of ovarian cancer, right? CA-125 is only likely to be elevated if you have ovarian cancer or maybe a few other types of cancer, but it's not a good test to trend and track things, And so having blood tests that help trend and track disease is super important, and Latoya, I think you brought up a really good point, the implications beyond just a breast cancer, looking at things like at metastatic disease, at liver mets and things. The one question I do have is it based upon the tumor subtype of the tumor that was removed, or is it looking in the blood in general at cancer, at circulating DNA that's shed? Because we know sometimes that tumors can mutate. You can have a TNBC and end up with a HER2 positive metastatic disease. Is it checking just a tumor that came out, or is it kind of looking for other signatures as well?
Just the primary tumor. So whatever was first diagnosed, that's the tissue that we collected, let's say 10 years ago, right?
Mm-hmm.
But then we do the whole exome sequencing on that tumor. So it's the original primary tissue. So if there is a new primary that develops, the tissue that we use for whole exome sequencing for a different primary will not be applicable to the new primary.
Gotcha. And I think that's something that doctors need to share with patients. This is looking for a recurrence of the tumor that you had, but it may not detect, new ones, but it helps us to guide management. I think we're all worried about the patients who come to see us who are concerned about their cancer coming back, and they're using the number as a surrogate for being cancer free. But I think that giving patients hope that's backed up by evidence is never a bad thing. Just because we don't know all of what to do with it doesn't mean we shouldn't be asking for the information. Doesn't mean we shouldn't offer patients their information, right? Like there's some value there from the patient side, even if the clinician doesn't quite understand how to utilize all that data yet. And the only way we're going to get there is to keep asking those questions.
Right. And another thing I always try to include when I'm explaining it to anyone is that this is not used to replace what we're already doing in the clinic. This is to be added to the toolbox that we're already using. So I can just remember when I was in clinic and we would do CT scans, and how many times on a CT scan do you see a lung lesion that isn't being definitively commented on that can cause the exact same anxiety, right? We're not really sure what this is. We'll repeat the CT scan in 3 or 6 months. And as a provider, you kind of forget sometimes of what that is doing to the patient, right? So why not add another tool that can help? Because what if you had that scan, right? And as a provider, you hate those scans, but then you could have ctDNA in hand as well. And what if your ctDNA in that moment was negative? That would help you rationalize through that scan, right? Or let's talk about immunotherapy. You can have pseudo progression, right? It's not very common, but when it happens, it's a very hard conversation to have. So let's say you are having pseudo progression, but then you have ctDNA also. ctDNA probably isn't negative yet, right? Because you're still probably having some tumor shrinkage going on, but you're going to see that MTM per ml trending downward. If it is pseudo progression, you're not going to see it skyrocket up. So it's something that you can use to help in those scans also that are that aren't telling you the exact picture in that moment, that there's some question behind it. ctDNA could help assist radiology, not replace it.
Okay,
So
what's pseudo?
Yeah, so pseudo with immunotherapy, it's the phenomena that's really, there's not a great explanation behind it, but when you have imaging, you start immunotherapy and it's actually being quite effective, you can actually see the tumor pseudo, so falsely getting bigger on imaging. And if you made a decision without having oncology information, you would say the disease looks worse, this treatment's not working. But in reality, the tumor just got bigger and it's going to shrink back down if you give it more time.
Great, great. Thank you. Yep.
Yeah.
Great, great. So Jamie, we left you over there in the corner.
Hey.
Dad. I mean, you're sort of watching this whole happen.
Mhm.
How is this forming your marketing? Because, a lot of what we do is really marketing, explaining stuff. Like I'm a 5-year-old to patients, you know what I mean? And this is a challenging thing to explain from a science perspective. Like, how are is this helping you even think about how you talk about it or?
Yeah, absolutely. I think one of the key things that we're trying to do is, we're a relatively new test. We've been around for about 3 years commercially. So of course, we're building materials, but we want the feedback from the community. Do we have enough resources for everybody? Is it super easy to understand? Is it easy to know how to order this test? How do we explain the scientific content? Maybe not kind of, the first time we talk to somebody, but how do we take those technical pieces and, share that information to the community if you don't have a medical background? So absolutely, I think this is, it's great to hear that Signatera, has made such a difference in so many women's lives, and we want to just keep speaking to the community and creating resources for everybody that help you understand what this test is and how to get it and how to access it.
Right,
So, we're always here to help, and we can provide more information on how to get in touch with us if you do have any questions, because we do have a team behind the scenes. We do have genetic counselors that you can talk to if you do receive results that you're curious about. We have a whole team to provide that information.
That's great. That's great. That's great.
And I think another thing to add that's really important when you're talking about Signatera is also to talk about hereditary testing.
Yeah, I was gonna bring that up.
so-
We have another test. We have another test to talk about. Let's go.
But for your family too. So I think that's really important, especially for a lot of patients with breast cancer. I find when I worked in the clinic, a lot of them were people with little kids and they're in that family planning phase too. So I think it's important when you're diagnosed to bring up hereditary testing to your provider and make sure it's addressed. Because A, it can impact the type of surgery you have. And B, if you're testing positive for inherited mutations, your children could have it too. So you want to be able to have them to have access to earlier screening or even some interventions that can help prevent them from getting cancer in the future.
That's great.
Yeah.
That's great.
I think it's what I hear from this and what I want people to take away from this is that we are, even in instances of TNBC, better able to personalize medicine more than we ever were before, right? Like at SABCS, we talked about how TNBC is defined by what it isn't and how it's not this, and it's not that. But we're able to really pare down what's going on in your tumor, what's going on in your bloodstream, what's running in your family, and better define these things in ways that are very meaningful for doctors. So when you get diagnosed with TNBC, especially, you're a candidate for hereditary cancer testing. I tell my patients all cancer is genetic, but not all cancer is hereditary. It's not all passed down generation after generation just because a tumor and those cells go haywire. But we can know, are you at risk for second cancers? Are you at risk for other cancers, colon, uterine, prostate, and sometimes you may be the only woman in your family. You may have a family full of men and you're thinking, okay, well, there's no breast cancer in my family, but it doesn't mean that there aren't mutations that can run in your family. And so if you have TNBC and you're watching and you were not offered genetic testing, you might not have met criteria back then. Right. But now we know that any triple negative breast cancer meets criteria for this hereditary cancer testing. And it is important for families, for siblings, for your own risk of secondary cancers. And so it's definitely something to talk about. Ricky, you always talk about knowing your her story. This is yet another reason to not keep it to yourself because, just because you say, oh, well, I'm too old, I'm not going to do a double mastectomy anyway, or whatever the case may be, it doesn't mean that it can't impact your whole family. Right. And so this is really that health information
So-
putting it in your hands and at your fingertips is so important now.
Mhm. And I think another important point is if you had genetic testing done like more than 5 years ago, it's an important thing to bring back up because there's a lot more genes that we're more aware of now. You know, genetic science and genetics has changed so much in the past 5 years. So just bring it up with your provider and see if, you know, should you get tested again? Because there might be some genes that weren't available when you were tested 5 or more years ago that now are, that would have some scientific reasoning to have certain types of screening or things done with your family that are more updated.
That's great. And Caitlin and Jim, you guys told me too that hospitals hold tissue for 10 years.
Yeah, we've been able to test up to 15 years of old tissue.
Wow. And the hospitals hold 10. So I'm going to try to find mine. So you could do
Mhm.
mine. Mine is 11 years old, but
Mhm.
I probably have some from 10 years ago from.
And we're
so
able to request it from the hospital that did your surgery to get the tissue.
For
Or
the
how do
tissue, for the tissue, yeah, because it's yours. It's just being able to get in contact with the right people, which your oncologist should be able to help you with that. But if you're talking about hereditary testing, that's a blood test. So that would just be access.
Right. For current blood, you know,
Yeah, but if you want to go backwards, yeah.
and do the Signatera test. So
Mhm.
gosh, we are like talking about two really important things.
Yes. So like just to clarify, hereditary is blood, Signatera is tissue.
Right. Right. So, and you really want both because you want to know, you want to know the fingerprint of your cancer, right?
Correct.
And then you can track to see whether it's coming back, and you want to know the DNA of your body, right, of your blood, because that could dictate the kind of treatment that you get, right? I mean, think about all the things that your DNA shows. Like, Mo, can you speak to that a little? What is DNA? What is that? Knowing that, no, what does that mean? What does that do for you as a patient?
Ask me that question again. What is the DNA?
DNA, like, yeah, what is the purpose of knowing your DNA and having your genetic testing?
So we are all born with gatekeeper genes, right? As far as hereditary cancer testing, because there's genetic and then there's genomic testing. Genomics, tumor testing, genetic, we typically think of hereditary testing. We're all born with these gatekeepers. They're like spell checkers. And when your spell checker is a little faulty, you remember word processors? I used to have one in college, and you'd be typing and you put your spell check in. Don't laugh at me, Nikki. I see that. You use spell check, and the term paper comes out with mistakes in it because your spell checker is off. And so there are gatekeepers for breast and colon and melanoma and prostate and uterine cancer, ovarian cancer, stomach cancer, many more cancers, right? And these genes are responsible. Everybody has them. We all have BRCA genes. We all have P53 genes. But sometimes there's a little glitch in the program. And when that happens, mistakes can get through. So knowing your DNA or knowing your genes can help you to know if you're more predisposed to certain cancers. It tells you how often you might need to be screened for those things. You got a mutation for a gene in colon cancer. Maybe you need to get a colonoscopy every 3 to 5 years instead of every 10. So it can be really useful information for screening, not just for when you get a cancer. And that's why we want people to test and to tell their families about it, because when families know early, they can screen earlier, we can detect things earlier, we can come up with interventions, we can reduce our risk factors and modify those so that we can reduce the chances of cellular mistakes even.
Yeah. And just to build off of that, the hereditary test that we have at Natera is called Empower, and it tests 191 genes that are all relevant to oncology. So that's one method that you're able to look and see what type of inherited mutations you have, if any.
So, Caitlin, there are different brands of genetic testing.
Yeah, there's
Yeah,
different
okay.
brands. Yeah,
So it's like you go to the store, you could buy Tide, All, or
just like that.
Arm & Hammer, right? So,
Yep.
so
Yeah.
how do you know which one to buy, right?
Yeah. So there's different ones. So it's just more so focusing with Empower. The really nice part about Empower is that we have a stat panel for breast. So that's very appropriate for this conversation. So let's say you're diagnosed with breast cancer, you're preparing for surgery that's going to be happening very quickly. We have a stat panel for breast that includes 10 genes that are related to breast cancer. And you can get that with a turnaround time of 5 days, but on average, a lot of providers get it back in 3 days. And what that can do is change the type of surgery you're having. Because if you do carry one of those inherited gene mutations, instead of getting a lumpectomy, it might push you towards a bilateral mastectomy to reduce those risks in the future that you have due to the inherited mutation. So that's something Empower has to offer, and that's a very fast turnaround time. It's one of the fastest. And then again, it has 191 genes that it can test that are related to cancer.
That's awesome. And, you know, we don't even know that. We think most of the genetic panels were based on white women's bodies.
Yeah. Yeah.
And so we don't even know if there's some Black genes we haven't identified yet, especially for triple negative, you know, so
Definitely.
are you guys on top of that research? Are you looking for?
Yeah, so the genetic education just has changed dramatically. Even if you look 5 years ago or even 2 years ago, there's so many more genes and modifications that are being done to the testing. So that's why I mentioned before, if you got your testing more than 5 years ago, I'd encourage you to talk to your provider and see if you should get retested, because there's a lot of research that is supporting, certain cultures or certain races or certain people with certain histories are being aligned with these mutations. Like before with breast, they only really focused on BRCA1 and BRCA2.
Right.
Now we're focusing on 10 of them. And even
10 of them, really 10 of them for breast cancer.
Yeah. And some of those are, even like if you look at prostate, it used to be, you never even tested for it, where now they're finding you can be positive for certain genes in prostate. And even though I'm a girl, some of those then would put me at high risk for breast cancer. So there's certain things just that it's just evolving so much. And there's so much research going on in the genetic arena overall with everything.
And it really could dictate even what chemo you get. There's so many
Definitely.
drugs now, especially if you're metastatic.
Yes.
If you're metastatic, the most of the really good immunotherapy drugs are based on your cancer DNA. So
Mhm.
so
Yeah.
important
And
to
I
know
think
that.
the other thing that's really cool about, or that Empower does, or what Natera does, is that if you do test positive, then your first degree relatives can get the Empower testing for free as well. And we don't only just test for the mutation you tested positive for, we'll test for the entire panel. So let's say you test positive for BRCA1 and we tested for 40 genes. Your first degree relatives won't only be tested on BRCA1, but that whole 40 gene panel.
Wow.
Yeah.
That's great.
Yeah.
And that's part of the thing, because we don't talk to our families. We need to make this a family conversation.
Yeah, it's very important.
Yeah. Yeah.
Ricky, I wanted to add something.
Yeah,
So I feel like also with receiving the ctDNA test, I feel like, I'm just speaking as a patient right now, is that this gives me that level of insurance or reassurance that I was looking for that I mentioned earlier, but also looking at it as a dual perspective for a patient and a provider. It is okay, we are catching a reoccurrence early. We're not going to wait until, now I have back pain and I thought I was in remission. And now when now we're getting, diagnosed again, the cancerous lesions have spread completely through my spine and all of my long bones. And I have not as a favorable prognosis versus if I have a ctDNA test that I have stored and it's mine, it's my personal signature. And now if I'm getting this, this test done in intervals, whether it's 3 months or Q6 months or whatever it may be, and if the test is not positive and the numbers are trending upward, then it's like, okay, we can get scans in, at this point in, whatever that physician may consider. And if there's just a single lesion recurrence, if there's a single tumor recurrence, then we can catch it earlier. And then we can have a more favorable outcome for this patient to live.
Yeah.
And that's how I see it.
Just radiate it.
So great.
Right.
So great. That's such a great point. My doctor, when I got to my 5-year mark, my oncologist said, okay, Ricky, you're good. Go live your life. Come back to me when you're symptomatic. I'm like, what the hell does that mean? Symptom, what? No way. Like, I don't want to do that. You know, I still go to him every year, but like, who wants to wait till you're symptomatic? This takes all this away. Like, you know,
Yeah.
I'm gonna do this like just to know, you know what I mean? And we have so much scanxiety when we go to get stupid scans. This is like, you know,
Let me play devil's advocate though. I got to do it because my colleagues are doing the same thing, right? You get this test, you get that scan, it shows nothing. Now you're like, but my number's high, but my number. And doctors are worried sick that they're going to get numbers that they don't know how to explain when the scan may not show anything and maybe too early.
Mhm.
And so I think that's where we have to get better at the precision of medicine, right? Because maybe there's some treatment that we need to initiate. Maybe you need to go on oral, you know, capside, oral Xeloda, right? Maybe you need to consider, so some additional scans that are more molecular in nature and not just a PET scan. So I think that that's where the conversation's got to go for the doctors to really be able to feel better about this information, because we know there's anxiety. We know there's, and we know how this plays in your mind. And
Right.
there isn't a test alive that can tell you that cancer is not going to come back. It hadn't come back right now, or it may never come back, but it's still, that part of it has to be balanced, I think. And because there's no test that's perfect, right? But
right.
this is, it's pretty damn close. Let's be honest.
Yeah,
This is pretty close.
Yeah.
But there
pretty
isn't
high.
a test that's going to put your mind at ease the way it was before cancer. It just
Right.
doesn't exist.
Right.
And that's the reason why we're trialing, right? That's the reason why when we trial, that's the whole reason, because to get those answers to those questions,
Thank
that's
you.
the reason why
Thank you. Yeah.
I'm donating my body to science, because we have to be studied so that when my 7-year-old develops breast in a few years, we can already have these answers to those questions so that my babies don't have to go through this deadly disease that I'm fighting.
Mhm.
So, you know, that, and that's all the reason why we're you know,
like
it
girls.
was so important for me to be in this trial. We
Right.
don't have the answers right now, but that's not to say we're not
Yeah.
going to have the answers in a couple of
Right.
years.
Got that right.
Yeah.
And so, but what I think that clinicians need to do also, or some of those providers, is I think that we are so accustomed to just treating the textbook classic presentation of a disease instead of treating the patient. Okay, well, all right, well, the ctDNA is now 15. You know, do a proper physical exam, do a symptom check on the patient. You know, you just make a shared decision making with your patient to see if you're going to proceed with imaging at this point, or repeat the test in a few weeks or a couple months or whatnot. And if it's still trending upward, you may not have caught a lesion at that 3-month scan, but you may catch it at a 6-month scan with a patient who has a 2-year-old and a 5-year-old at home, and you don't want this tumor to metastasize all throughout her liver, or
Right.
wherever it may be, and kill her. You know, I mean, I think for especially patients like myself who have triple negative, where we don't have the maintenance therapy like Ricky was
Right.
saying, like, why not? It
Yeah.
doesn't hurt me
Yeah.
to get this test. And you know, that's just my perspective of it. You know, I hate to play devil's advocate.
I have a question. Given, Jamie, this is for you. Given that, you know, that when we trial and touch, we're doing this, do you have an idea, or are you considering making like a global impact to get this information out to communities of color that need this type of, that this testing is available?
Yes, that's a great question. Absolutely. So, you know, we did just launch in the breast cancer space. So really, you know, this year was a year to make sure that everybody had this information, but we're realizing that we're not getting the word out fast enough. People really want to know. And 2023 is going to be that year where we're really trying to amplify this information throughout, especially, you know, advocacy organizations, places where people will receive breast cancer or just breast health information. So we really are trying to push all this information out so people just know that it's available and can talk to their doctors and their care teams like, is this right for me? Or maybe, you know, you have family members that could potentially use this information. So I think that absolutely, like, we are trying. 2023 is going to be the year that we're really pushing out. But yeah, if you have any suggestions, please.
That's
you know, let us-
exciting.
yeah, it's
I could do your voiceover. Welcome to,
She could do your voiceover. She
I
could do,
could.
but you know what though, what, you know, it's kind of secret and I promised you I wouldn't talk about it for a minute. We're launching a new campaign for young women about Black breast health. And so we're going to partner with these guys. And that's why they're here, to kind of use our platform to talk about it. And we're going to try to help them to get this word out because it's so important for our patients to have this information. So important. But you guys, we have a question from Celeste, my friend Celeste from Atlanta. Where do you find information that helps you prevent triggering cancer if your test results indicate you are predisposed? Maybe she's like, maybe that's not the correct term for cancer.
Yeah. Say it one more time.
Where do you find information that helps you prevent triggering cancer if your test results indicate you are predisposed for cancer?
So I'm thinking what she's saying is that if she's testing positive for inherited mutations, and how does she prevent cancer from happening? That? Yeah. So the correct method would be, so she inherited the genes. So she has the genes. There's nothing you can do to reverse
Right.
that gene.
Right.
But the second thing that you can take action in is if you do test positive and certain inherited genes, you can start surveillance at earlier time points and with different type of imaging modalities, depending on what gene it is. So there's actions that are supported by guidelines based on if you're testing positive for certain genes. So it could just be screening, or it can be more invasive, like a surgery, just like, let's say you're at risk for certain female diseases, you can get and you're done having kids, you can get your
Ovaries taken out. Yeah.
Yeah. So there's more intense methods you can do. There's less intense screenings that you can do. And it's all based on which mutation is being tested positive.
Yeah, but we do know that if you do have the gene, so the incidence of breast cancer is 1 in 8 women, right?
Mhm.
Maybe slightly lesser, but if you do have the gene, it's the opposite, right?
Correct.
Like the odds are 8 to 1 that you're going to get breast
Right.
cancer.
You're
So
much higher.
so you want to do something prophylactically, or you want to like be aware of what you're up against, because the likelihood of you getting cancer is pretty high.
Yeah. And you want to catch it early. The earlier you catch it, the better. So that would be the point of doing earlier screening,
Right.
or removing parts that make it so you don't get the cancer in general.
Yeah.
So yeah.
There are pharmacologic things you can do, right? We call it chemo prevention. Taking things like tamoxifen can reduce the risk of breast cancer by up to 20 to 25% for some patients. Diet, exercise, lifestyle modification. There's no perfect, prescription, I think, for how to prevent it, but we can absolutely screen for it early, and we can do those prophylactic surgeries and things when we're in that window, and so we've kind of refined that time period. Are you finished having children? Are you between 30 and 40? And we kind of started to tease out when it's best to do that. But we're getting to the point now where there's some genes you have mutations in, CHEK2, ATM, other genes that are, we call them moderate penetrance, right? And so now we're looking at or high penetrance and moderate penetrance genes. So how likely are you to get cancer if you have those gatekeeper mutations?
Right.
And we can look at the parts of the genes. You'll hear this term SNP, single nucleotide polymorphisms. We can even look at the pieces and see, well, okay, if you have this piece and it's active, or this piece and it's missing, you might have a mutation, but you might not be as likely to get cancer as the next person with the same mutation.
Right.
So it's getting so much more refined. And it's why, like Toya said, it really underscores the importance of making sure that our genetic material is counted in the mix, so that
Right.
we can say, relative to us, to our ancestry,
Right.
that we are represented by these tests, and that these tests actually work on us.
Right. So Mo, can you take tamoxifen prophylactically for triple negative?
Not for TNBC,
Yeah, I didn't think
because
so.
once you have a
Yeah.
breast cancer, and that's a little bit different. But if you are high risk, you can consider reducing your risk with estrogen blockade, especially if you have a BRCA mutation. Yes.
All right.
And there's a
But
lot
but
of
not
like,
for
high
triple
risk
negative, no.
genetic-
Right.
Yeah. And like here, like right now I'm in Chicago, there's a lot of high risk genetic clinics. So that's like what they specialize in too. So you can get a wealth of knowledge from them too.
But it goes back to knowing your her story, talking to your mamas and your aunties and your grandmas and your dads. and
Yeah,
the
and your dads. Like,
family,
I feel like that's
right.
overlooked a lot.
Yeah, talk to your dads and know her story, know where you came from so you can get ready. And then know that if you do get sick, you can get this test and you can be like Nikki and Toya and say, yay,
Mhm.
it's not here, it's gone, right? And how cool is that to be able to say that? You know, you don't have a lot of wins with cancer. So to get a win.
It's a
Get a
big
W in the column finally.
Right. That's what you said too. You said I got a win finally, right? I love it. I love it.
Especially TNBC. That's major.
I hate this, Doug. We hate this.
Yeah.
Yeah, it
That's
is.
major.
Wow.
Absolutely.
You guys are awesome. Thank you for this valuable information. And we're going to write an article for Black Doctor about it to go on the website.
Awesome.
So, and we're going to write an article so that we have more information. And if you have questions, I know where to find these ladies, but if you guys, is there a place people can go to get this information, you guys?
Yeah, if there's any questions on Instagram, we have an account called Natera Genetics. And if there's any questions, you can message it there, and then we can triage it internally and have the right person reach out to the patient or person messaging the account.
Great. I'm going to put that in the comments, Natera Genetics on
Mhm.
Instagram. Great.
Yep. And then if you don't have Instagram, you can always go to natera.com and click on contact. And they'll have a list of phone numbers that one's for oncology, one's for organ, and one's for women's health. Just click on the oncology one. And then when you call, they'll be able to get you where you need to go.
Great. So nateragenetics.com or natera.com.
Just natera.com.
Great. We'll put that in
And,
there.
and the moral of the story is keep pushing, right?
Yes,
Keep asking these
advocate.
questions, keep asking your clinicians, even if we
Right.
don't know all of what to do, is there somebody that you can call or that you can ask and that you can you get better informed about this, doctor, so that you can help me to make good decisions about my health? Can we partner with this? How can this happen? What can you give me that is useful, as opposed to just sort of asking for something for permission and getting the no?
Yeah.
Right? Like that, our job is to partner with patients.
Yes.
And it's to help them understand what we understand in a way that makes it easy for them to understand.
Yes.
And
that's what medical affairs is truly designed for, is to come out into the field and educate the physicians, the NPs, the PAs, the nurses, the medical assistants, and how to order this test, how to use it. And when you get into tough situations, getting medical affairs involved to help you as a physician understand the test and what next appropriate steps there are.
Great. Great. Well, thank you guys so much. Thank you so much. And thanks, we love to give information. We love to give information.
absolutely.
No problem.
No. So Mo, next week is going to be one of our favorite shows that we do before Christmas.
Yeah.
Can faith and fear live in the same house?
All right. We got to talk about it.
Got some
You know,
pastors
especially-
on the line. We'll see what they talk. And every year it's a big debate. So
It
if y'all
is.
want to come back and talk about that with us.
Yeah,
I mean-
absolutely. You know, I think going into 2023, we don't necessarily set resolutions for the year, but we can resolve some things in our spirits before the end of this year
Yeah.
and resolve to do some things differently, and so it's a good time to contemplate these things and to begin practicing. I always tell my patients, if you think you're going to start something on January 1, start now.
Start
Give
now.
yourself a couple times to practice and fail. You got to
Yeah,
stop
right.
smoking. Well, let's just stop now. Let's practice.
Right.
You're gonna start that new fitness regimen. Go for it. Let's just start practicing now. So we can talk about what we're doing to practice the behaviors we want to manifest in 2023, and we hope it's been relatable and reliable and real. That's what we set out to do every Wednesday night here on Black Doctor. We are so thankful to our sponsors, to our participants, to our experts, to our advocates, to the people watching, to Ricky for even hosting and thinking of this show, and to all of you. So we'll see you next Wednesday.
And thanks, Natera, for joining us today.
Yeah, thank you for having me.
Thank you to
Yeah.
our
Thank you.
sponsors.
Thank
Happy
you.
Happy holidays.
Happy love.
Rusty love.
There it
I'm
is.
doing
Rusty love.
W. Win.
I love it.
Win.
With that
Yeah,
W,
you got
turn it into a heart. Love it.
See you next week. Love you.
Bye.
Thanks.
Bye. Bye.
Bye.